talking to you about surgical complications.
All right, so hello, I'm Abdullah. I'm one of the fifth-year medical students at Cardiff, and as Halima said, I'll be your host today. So switch to presenter view and then we can begin. These are just our sponsors. So we've got quite a few learning outcomes to cover today. So as you can appreciate, we won't be able to go into too much detail for each one, but all the information will be present on the slide for you to have a look at later. Okay, so we'll start with hemorrhage. So when you talk about hemorrhage, we usually just mean bleeding, but bleeding either into the drain, somewhere inside the body, which we can usually see as a hematoma, or usually out of a wound. They're the key three things we look out for. And there's three types of bleeding that you'll come across. And I just put them here in chronological order. So starting with primary hemorrhage, that's the sort of hemorrhage that starts during a surgery when we've accidentally cut into a capillary or an artery or something. And usually it's resolved during surgery through cauterization. And in severe cases, you may need to replace blood, but usually it can be controlled quite well. The next type of hemorrhage is called reactive hemorrhage, and that's when that's a hemorrhage that usually happens or becomes apparent within 24 hours of surgery. But actually, this can actually start in surgery, and this can get a bit confusing. But to simplify it, the reason why we don't necessarily see it during surgery when it starts to happen is because the patient usually is under an anesthetic, and they're usually hypotensive, and usually they have peripheral vasoconstriction. So as you can imagine, even if a bleed starts, it's unlikely to become apparent to the surgeons at the time. However, post-operatively, once that blood pressure rises again and the anesthetic wears off, that's when you see a hemorrhage. And sometimes you will have to replace blood and re-explore and try and find out where the source is so you can adequately control it. And finally, there's something called a secondary hemorrhage. And this usually happens 7 to 10 days post-operatively. And it's usually due to some sort of infection, which actually erodes into the vessels. And as you can imagine, this takes quite a while. So that's why it's the latest one out of all the hemorrhages. But it's important to remember that secondary is actually the later one, and reactive is before secondary. Okay. So you need to know the presentation of hemorrhagic shock because it's quite common, and it's important to recognize. And the two key things to remember is with hemorrhagic shock, you'll get tachycardia, and the most sensitive thing you'll get is a raised respiratory rate. And you'll also get dizziness, agitation as well. And because the kidneys are filtering out less blood and there's less perfusion of the kidneys, you'll get decreased urine output as well. And through these measures, you can classify the type of hemorrhage. So the lower the urine output, the worse it is. And as you can imagine, the greater the blood loss and percentage of blood loss, and the more severe it is. So this is an X-ray of someone post-operatively who's developed a certain surgical complication. Can anyone tell me in the chat what they think is going on here? So I've circled it just so to make it a bit easier. Does anyone want to have a go? You can message me privately if you're shy. So we've got pneumothorax, we've got collapsed lobe, atelectasis. Yeah, some good suggestions. And so yeah, so the majority is actually correct. So this is atelectasis, and this is quite a common post-operative complication. Wait a second, it's not. Okay. So it's very common and actually can occur and is defined just by the complete or partial collapse of the entire lung or lobe. And usually it's due to bronchial secretions obstructing the airway. And that's why you get the symptoms of dyspnea and low oxygen saturations in the blood. And as you can imagine, the most important thing is to get rid of those secretions. And that's why the management is mainly conservatives, because you just want to do chest physiotherapy to get rid of those, as well as upright positioning as well. And this is just a nice illustration to show what's actually happening. So the alveoli are being collapsed, and that's significantly reducing the lung volume, which explains the dyspnea the patient will experience. Another common complication is post-operative nausea and vomiting, which actually affects 20 to 30% of patients 1 to 2 days after an operation. So it's very common. And it can simply be due to the actual procedure or the anesthetic given, or even the pain and even the painkillers given. So a lot of causes. And some key risk factors to remember is it happens in females, in those who are non-smokers, and when certain anesthetics are used, usually the volatile ones. And the management just involves antiemetics. The preference for certain antiemetics changes between hospitals. So usually if you're rotating around several hospitals, you'll probably use different antiemetics. But in terms of guidelines, usually for prophylaxis and rescue, either ondansetron is given or cyclizine. And for prophylaxis, dexamethasone can also be given, and rescue, you can give prochlorperazine as well. It's very useful to remember for exams that ondansetron can cause prolonged QT intervals. So you want to make sure the patient isn't predisposed to this, possibly by doing an ECG at the time of giving it as well, or before giving it. And cyclizine is you have to exercise a bit of caution if someone has heart failure or the elderly as well. Dexamethasone, again, not the first choice because it can cause hyperglycemia, which would obviously be bad for diabetics. And also, because it's a steroid, it can cause immunosuppression. So we don't want to give it to someone who's already immunocompromised. Prochlorperazine is a dopamine receptor antagonist. And so we definitely want to avoid it with patients who have Parkinson's disease because it can worsen their symptoms significantly and possibly even permanently. So we definitely don't want to do that. Okay, so we'll move on to our first MCQ, and you can just put your answers in the chat. So which of the following is the most appropriate description of delirium? So we'll give you about 30 seconds. Yes. Okay, so the large majority are going for B. In fact, everyone's gone for B. So yes, well done. It is in fact B. So delirium is just the acute state of confusion characterized by two key things. So it's disturbed consciousness and reduced cognitive function. Very common in the elderly post-op and sometimes confused with dementia, and it's very important to differentiate the two. So delirium tends to be very acute, unlike dementia is quite insidious and it's quite progressive and gradual. And delirium is also quite classically fluctuating, and that can come up in question stems where it kind of fluctuates in kind of severity. But dementia, as you can imagine, again, is quite progressive and gradually gets worse. The attention is usually poor in delirium, and also it's common to get delusions and hallucinations. In dementia, you can still get some hallucinations, especially in certain types like Lewy body dementia, but in terms of the other types, it's much less likely. So there's certain risk factors that you just need to be aware of. And interestingly enough, those who have dementia are more likely to develop delirium, which kind of just adds to the confusion of it all. But those who are more than 65 years old are more likely to get it, and with several other comorbidities are more likely to get it as well. Causes are quite important to know. Usually infection is very important, pain and dehydration, and even constipation is actually quite a common one. Simply moving someone to a different ward as well can actually make delirium even worse. And that's why during the management, we want to identify the cause and make sure that they're being managed in an appropriate environment. So somewhere where it's quiet, regular routine, and possibly somewhere where they're familiar with. So the place they were first admitted or the first ward that they were admitted to. If they're causing significant disruption and they're possibly even aggressive, which can happen, sometimes you may need to calm them down quite quickly. And usually the first line treatment for this is haloperidol. But this can actually exacerbate Parkinson's and Lewy body dementia quite badly, and can actually cause permanent worsening of symptoms. So it's very important to make sure that this patient doesn't have any of these conditions, and if they do, give lorazepam instead. So moving on to our second MCQ. So which of the following contributes to abnormal blood components, specifically the hypercoagulability of Virchow's triad? Okay, so we're getting A. Just 10 more seconds. Let's see. Okay. So the correct answer is actually A. And the reason for this is, if you remember, Virchow's triad is the triad of stasis, endothelial injury, and hypercoagulability. Now, I understand why someone put C there, because it's a very common cause, but remember, stasis is the long haul flight, and we're only asking for the hypercoagulability part of the triad. So that's kind of the trick in this question. And that's anything that causes kind of some sort of hyperviscosity or hypercoagulability. And in this case, the only thing present in this on this slide is the factor V Leiden, so factor V Leiden. And other causes of the hypercoagulability can include something like protein C or S deficiency, nephrotic syndrome, antithrombin 3 deficiency, any severe trauma. Cancer is a very common cause of hypercoagulability, and you're more likely to develop DVTs with cancer. Smoking as well. Certain contraceptives can increase DVTs, especially those that have estrogen in them, including the combined oral contraceptive, and obesity as well. So a lot of things that can cause this. Okay. So DVT is very common, up to 25 to 50% of post-op patients, and actually up to 65% of below knee DVTs are asymptomatic. So you need to have quite a low threshold for suspecting a DVT. And there's a lot of risk factors here, but it's very important you familiarize yourself with all of these. And the way I remember it is just consider all the ones that cause stasis. So you've got the immobility, you've got the surgery, pregnancy. All of these are going to cause stasis of blood. And then cancer, as I mentioned before, thrombophilia for the hyperviscosity. And estrogen, like I said, so the contraceptives as well. So a lot of risk factors, but it's very important you know them, because they can appear anywhere in the question stem and kind of lead you towards the direction of a DVT or a PE. Signs include fever, pitting edema, and the most important one is calf tenderness, and that's why in respiratory exams we always squeeze the calves just to make sure they don't have any tenderness there. Signs of PE, there's tachypnea, crackles, fever, and tachycardia. The most sensitive one is actually tachypnea, but on an ECG, it's important to also realize that tachycardia is the most common finding that you'll find. And sometimes you may have heard of the S1Q3. I'll put that in the description. Sorry, I've forgotten that, but there's a specific one where it's quite a limited finding on the S waves and T waves and certain leads. But the most important one you need to know is just tachycardia, and they're more likely to have PE if they have tachycardia. And the way we investigate this is we do a Wells score. And I thought I'd put the table for the Wells score for a PE and a DVT alongside each other, because they're actually a bit different, and they're scored a bit differently as well. You don't need to memorize all the things in the Wells score, but you just need to familiarize yourself with how they generally mark it, and just be aware of what's in the Wells score. And the way to remember this is just, so if I just get my laser pointer out, the way to remember this is in the PE Wells score, for example, it'll include certain risk factors, so very important malignancy and immobilization will give you points, but also key signs and symptoms like hemoptysis and tachycardia, like we said. And this is the same with DVT Wells score. It'll have specific signs and symptoms, so calf swelling, pitting edema, but also predisposing factors like an active cancer and a previous DVT as well. And then you need to know the score. So this is quite important. So just all you need to remember for PE is 4, and for DVT is 2. So if they have more than 4 points, then it's likely for a PE. If it's a DVT, then they need 2 or more points. So it's important to realize that here it says more than 4 points. So it could also say 5 points or more. So if they have 4 points, then it's actually unlikely. And that's why sometimes people kind of make a mistake here, because they think 4 is the threshold, but it's actually more than 4. Okay, so just be aware of that. Okay, so going through the algorithm of a DVT Wells score. So if someone has 2 points, for example, then they do have a likely DVT. And what we want to do is get imaging straight away. And that's the same case with a PE. We want to get imaging straight away. But for DVT, we want a leg ultrasound, and ideally within 4 hours. If that's not the case, then we still want to get the scan. But because it's very likely they have a DVT, we'll give them anticoagulation anyway. And as we call it, in the interim period, we'll schedule the scan within 24 hours, and we'll also do a blood test as well, a D-dimer. If the scan is positive, then it's already diagnosed. That's the best way to diagnose it. If the scan is negative, then we want to do a D-dimer. And if it's positive, then we'll stop the anticoagulant, but we still want to repeat the scan because we've suspected it for a reason. And this scan is usually done within a week. And if it's negative, we don't have to consider it anymore, and we can just consider another diagnosis. If it's positive, then it's diagnosed. If the Wells score is less than 1 or 1, then we want to do a D-dimer. So we don't jump to the imaging straight away. We want to do a D-dimer just to rule it out. If it's positive, we go down the other route. If it's negative, then we can just rule it out and say, let's consider another diagnosis. And as with this side of the algorithm, if we can't get it within 4 hours, we give them anticoagulation just in case, and then we do a D-dimer as soon as possible. So the PE, again, very similar, but remember it's 4 as the threshold, not 2. So if it's more than 4, or if it's 5 or more, then we want to get imaging straight away. In this case, a CTPA. And interim anticoagulation, again, if we can't get it straight away. If it's positive, it's diagnosed. If it's negative, then it's unlikely to be a PE, but if we suspect a DVT alongside it, then we might want to do a proximal leg ultrasound, like from the other algorithm. If it's unlikely, so less than 4, then we want to do a D-dimer, ideally within 4 hours. Again, not possible, we give interim anticoagulation. And if it's negative, we can rule it out. If it's positive, we can just go straight to the imaging, okay? And it's important to remember that we can't always do CTPA because it does have some risk factors. So we need to use a contrast because it is a CT scan in the end. So for those with renal failure, it's unlikely we're going to give them contrast because it can exacerbate the renal function. So we do something called a VQ scan. And you also have to weigh the option of a VQ scan and a CTPA in someone who's pregnant as well, because both of them have risks and benefits as well. So in terms of the management, it's quite simple. We just want to give them a direct oral acting anticoagulant. So no longer do we use warfarin because it's quite hard to monitor. However, again, there's an exception for renal impairment. If the GFR is less than 15, then we favor low molecular weight heparin. And this is the case in pregnancy as well. If it's a massive PE and they have something like a saddle thrombus, the question stem will usually have a very low blood pressure reading. That's when we thrombolize them. So that's the key kind of difference there. In terms of the duration of the treatment, if it's provoked, which just means if we know the cause, so if they've been on a long haul flight, then we only need to give them 3 months worth of anticoagulant. If we don't know the cause, so it's unprovoked, then we usually extend that period to at least 6 months. And if it's active cancer, again, it'll be a bit longer, but in the period of 3 to 6 months, but usually 6 as well. Okay, so another MCQ. So which of the following is the most common cause of acute respiratory distress syndrome? And yes, thank you, Thomas. S1Q3T3. Yeah. Okay, so we're getting some D's, some A's. A B as well. So it's a bit more spread out this time. Okay. So well done to the one person who actually put A as the answer. So this is a bit of a trick question, but the most common cause is sepsis. The most common cause is an infection cause, but sepsis is the most common infectious cause. And obviously you can get co-current pneumonia and it can be a cause of pneumonia, but sepsis is the key one. That's the main cause, okay? Although the others are causes as well. So acute respiratory distress syndrome is pulmonary edema, but it's non-cardiogenic, and that's a very important point. And it's the same mechanism as normal pulmonary edema, so it's just increased permeability of the alveolar capillaries, and this increased permeability just causes a lot of fluid to accumulate in the alveoli, and it's very serious. So the mortality is around 40%. And as we can see, the most common cause is sepsis, but it's important to note the other causes like trauma and even acute pancreatitis as well. So you might get someone with acute pancreatitis and suddenly they develop a shortness of breath, and it's most likely ARDS. Okay. So the clinical features, again, difficulty breathing, as you can imagine, lung crackles because of the edema in the alveoli, elevated respiratory rate, and low oxygen saturation. And the thing here I've mentioned is the PO2 FiO2 ratio of less than 40. So when we say PO2, we just talk about the partial pressure of oxygen, so the concentration of oxygen in the blood. And then FiO2 is just the fractional inhaled oxygen. So that's the percentage of oxygen inhaled. And usually they're on oxygen of a certain percentage to kind of supplement their oxygen. And we know this just from the mask that they're wearing, for example. So this is quite easy to calculate. And when the ratio is less than 40, then we suspect ARDS. The management, because it's so serious, they usually are managed in ITU. They may need ventilation, will definitely need oxygen, and even organ support. Because infection is the most likely cause, they'll most likely need antibiotics. And like a lot of COVID patients, they will need prone positioning and muscle relaxation as well. Post-operative ileus is another common complication, and it's a complication involving surgery of the bowel, and especially surgeries that involve a lot of handling of the bowel. In terms of the mechanism, it presents very similar to a bowel obstruction, but it's caused by reduced peristalsis, and so it's considered a pseudo obstruction because nothing's actually obstructing the lumen, but it's just the fact that the muscles aren't moving the food along that it causes a backlog and it causes an obstruction. So the clinical features, again, very similar to a bowel obstruction. So you get the distension, the pain, the nausea and vomiting. Inability to pass wind is very important to ask in histories because it indicates a very severe obstruction and a complete obstruction. Usually you can hear wind passing because there's usually a bit of space. And that's what we call tinkling bowel sounds heard on examination. When there's absent bowel sounds, then it's very serious. And usually they may need even surgery straight away. And it's interestingly caused by deranged electrolytes as well. And that's why it's important to check things like potassium and phosphate and magnesium. And again, it's very similar management to bowel obstruction. You want to keep them nil by mouth, NG tube to allow for free drainage, and IV fluids to ensure that they're normovolemic. And this is a bit of a hard concept to understand as well. When you actually get bowel obstruction, you get something called third spacing. And that's when a lot of fluid goes out of your vessels and the reason out of your circulation. And the reason this is because we don't realize it, but when our bowels actually secrete a lot of gastric and other juices and fluid to kind of digest all the food in our digestive system. But if it's blocked midway, it can't be reabsorbed again. So that's what usually happens. All of this is reabsorbed back in, so we just don't lose a lot of fluid. But if there's an obstruction, then we can't absorb it lower down. And that means that it's continuously being produced, the secretions, and they're not being reabsorbed again. So that means a lot. So people can actually be very hypovolemic, and that's why IV fluids are very essential in treating a patient with this kind of obstruction. And TPN, which is just total parenteral nutrition, and that's just when they give a patient all the nutrition they need through a vein, and that's if they definitely can't tolerate anything. But that's in severe cases. Okay, so this is an X-ray. Can someone tell me what they think is going on here? So again, I've just circled the key thing I want you to concentrate on. I don't have any ideas what they're looking at here. We've got fecal impaction. Right, yeah. So well done, guys. So it is, in fact, just constipation. Wasn't really a trick question. And sometimes people can start saying, oh, this is ulcerative colitis, there's fingerprinting, and it gets very complicated, but it's actually very simple. It's just constipation, and you can see the fecal matter there, and it's just built up. So constipation, and it can be defined as just infrequent bowel movements, usually less than 3 a week, but it's important to tailor this to the patient. Everyone has their own kind of bowel movement kind of schedule, let's say, and it's very normal for some people to go even once a week, and that could be normal for someone. So it's very important to ask the patient, you know, what's normal for them. But that's just a guide, and it's usually hard, quite dry, and because of this, it's usually painful as well. There's a lot of causes, and it can be split into physiological, pathological, functional, and iatrogenic. Physiological can include just simply a low fiber diet, low fluid intake as well. Pathological could be certain conditions like hypothyroidism. Functional could be anal fissure. So these are extremely painful. So a patient might want to go, but they'll hold it in just so they don't experience the pain. And iatrogenic, so opioids, very commonly tested concept. So things like morphine are very constipating. Those on codeine as well, very constipating, and usually they give a laxative as well when they're prescribing these kind of medication. And for those who've ever had to supplement with iron, so using ferrous sulfate, for example, will know that you can get very black, tarry stools, which are quite hard, and that's because it's very hard to digest. So the clinical features, this involve abdopain, lower abdopain to be specific, distension, nausea and vomiting in severe cases, and just loss of appetite. And you may want to do a digital rectal exam just to assess the degree of impaction. And a lot of the time, the Bristol stool chart is used, and it's used in a lot of ward rounds as well, because it's just an easy way to classify the look of the stool and what we think it is in the notes. And usually we aim for kind of a type 4 kind of picture. For those who are severely constipated, they kind of get something that looks a bit like rabbit droppings, basically, but very hard and painful. So the management is usually conservative. Sometimes you can get away with just giving them a lot of fiber, encouraging hydration, a lot of fluids. But most of the time, unfortunately, you might want to opt for a medical option, so laxatives. And specifically in post-operative situations, you want to start with either an osmotic laxative, which kind of softens the stool, or a stimulant like senna to kind of encourage that peristalsis. And then you reserve for bulk forming later on. And then rectal medications will include something like suppository, which it can give quite immediate relief, so it can be a good option if the patient's really struggling as well. So again, unfortunately, when we do surgery, we do have to, in a way, make a wound, and we have to do an incision. And sometimes these fail to heal, and often reopen as well, and look like they've healed. And this can be a big problem for surgeons, especially in abdominal surgery and general surgery. And sometimes it's classified into superficial and full thickness. Superficial being when it just affects the subcutaneous tissue in the skin and the rectus sheath is intact. And full thickness is when the rectus sheath is also not healed and it's still separated. And this is usually a bit more serious. So there's various risk factors for this, including patient factors like age, gender. Certain medication like steroids, smoking can impair the healing process and is very important to stop, especially around surgery. Intraoperative factors, so as we said, abdominal surgery, if you're cutting through a lot of layers, so it can be sometimes hard to heal after that. Length of the operation as well, and if you get an infection, again, it's harder to heal with infection. And post-operative, if someone is known to have poor tissue perfusion, then obviously they're less likely to heal as well. Or if simply they have a lot of intra-abdominal pressure through regular coughing, for example, then it could just open up a wound as well. So the clinical features, as you can imagine, it involves visible opening of the wound, and usually in full deep thickness types, you'll get a bulging wound with seepage of this pink serous fluid, which sometimes can be bloodstained as well. It's a clinical diagnosis, and if it's superficial, then you may only need to wash it and just give simple wound care. If it's deep, then unfortunately it can be quite painful, so you might want to prescribe analgesia. There might be an underlying infection, so you want to give antibiotics. And usually you'll have to send them to the theatre again for reclosure. However, in sepsis and necrotizing fasciitis, you actually manage it as an open abdomen, usually using a vacuum dressing, just to prevent any infection as well. Surgical site infection, again, another complication which is quite common and is actually one of the leading causes of morbidity. And there's 3 key types you need to know about. So the superficial, deep cavity. So superficial just being the skin and subcut. Deep being a bit lower down, so the fascia, maybe the muscle as well. And cavity is just the area underneath the overlying skin tissue that you've operated in. So it could be a joint cavity or an abdominal cavity as well. So again, patient risk factors can be split into patient factors and operating factors. So patient factors will always just include the health of the patient. So if they're obese or not, if they're smoking, if they have poor glucose control, so if they have diabetes. And operating factors are usually the length of the operation, again, if antimicrobials were used as prophylaxis or not, And actually, a very common one nowadays is preoperative shaving, and usually this was common practice, but it's actually been shown by a lot of studies that preoperative shaving can actually increase the risk of a surgical site infection. So we actually avoid that now. So clinical features will include erythema, pain, pus because of the infection, and persistent pyrexia as well, and obviously opening up of the wound. And we want to kind of isolate the organism that's causing the infection, so we can do that through swabs, blood cultures if they've developed sepsis, and very deep collections, we might want to do imaging as well. And management will usually just involve allowing just drainage of the wound and allowing that pus to drain out. Empirical antibiotics until we've isolated the organism, and we can tailor antibiotic usage later on. But in the meantime, we want to give antibiotics as soon as possible. But because there's such a high morbidity, prevention is the most important thing. And we want to give prophylactic antibiotics, avoid removing the hair, doing appropriate ANTT, and just monitoring the wound so it can be operated on or treated as soon as possible if there is an infection. And that is the end of the presentation. Thank you very much for listening. Any questions? And the recordings will be uploaded later on to the website as well as the slides. And I believe Halima will put the feedback link soon. Oh yes.
Yeah, I've just put it in. I put the feedback form in. If you could do it, please. Those who complete it will be given the recordings and the presentation. Thank you, Abdullah.
Thank you very much. I'll just stay here just a few more minutes if anyone wants to ask any questions. Otherwise, it's pretty late, so